So no disclosures, no relevant conflicts of interest. We're here today to talk about depression in older individuals, common patterns, particularly in the older individuals, key factors in the aging process that affect how depression presents, and some elements of how it's treated, causes and etiologies of depression, management in older individuals as one of the most common health issues in elderly individuals that complicates other medical illnesses, as well as being a huge impact on their social determinants of health. Understanding the importance of the holistic approach of medical, social, and emotional, and discussing how community health workers can be a critical element in the help and management of depression. This is really one of the most common illnesses in older individuals, one of the most difficult issues for older individuals, and one of the most challenging to go ahead and get a handle around. As in other groups, we're going to rate your self-confidence in terms of the management of assisting patients with depression and families with depression as to very well, only somewhat or minimally prepared to do that. Marion has opened the poll. She'll leave that open for a minute or two, give you a chance to submit.
And we'll give it a few more seconds if you would like to complete the poll.
All right, we got some overachievers who already feel very well prepared, which is great. About a third of the group feels they have some information, and about 40% feel they have somewhat, and about 15% are here particularly to get more information. Now that we can't afford heating oil, our pension check is finally good for something. Always got to start with a little humor when we're going to talk about depression. Honey, I've been through 2 world wars, the Great Depression, taught over 3,000 children, administered 4 elementary schools, and outlived every one of the people I've worked with. I'm 89 years old, and you're telling me it's bedtime? So it's important to remember that people talk about older individuals as being depressed very commonly. If you ask the sort of reality of what older people are living through, they have chronic health challenges. They may have lost a spouse. They may have lost some of their children. They may have lost some of their mobility, their ADLs. If we put that sort of burden on a 35-year-old, I think a lot more of them would be unable to maintain. And I think of older people as having what I call durable mental health, which is that they basically have been through a lot and they're managing through one way or another. Oh, you're not in the obituaries. Oh, that's good to hear. We met in the ICU and had a romantic encounter. So one more poll and then we'll get into the meat of it. Depression in older people is uncommon, untreatable, treatable, or requires hospitalization.
Give it a few more seconds if you would like to complete the poll.
Everybody knows that that's treatable. It is very common, probably 10 to 15% of the population. It is very treatable. There's multiple different types of treatment, both cognitive behavioral therapy, talk therapy, medication therapy, including electroconvulsive therapy, which has only really one indication left, which is a true psychotic depression. But it does have some role in that. The vast majority of people with depression do not require hospitalization. Most people can be treated as an outpatient. Most people are actually treated in a primary care setting without having to be involved with a psychiatrist. And most primary care providers feel comfortable going through 1 or 2 of this, SSRI medications prior to referring to a psychiatrist. In terms of how prevalent it is, maybe 2 to 5% of the community dwelling elderly Among chronically ill, about 10%. But if you move into the places where you're going to interact patients hospitalized, geriatric inpatients, cancer outpatients, cancer inpatients, stroke, Parkinson's, status post-MI, we're talking 40 to 45% of those populations are having issues with major depression. And it's important to differentiate. When we're talking about major depression, we're talking about more than just the classic boredom or loneliness. We're talking about a depression that actually impacts on your ability to function in day-to-day life. As we talked about in the other two lectures, function is the key element that determines what is a true illness in older people and what is just a condition that's occurring in older people. There are many risk factors. Female gender, again, we talked about the fact that the vast majority of older individuals are women. Social isolation. There's a huge amount of issues with social isolation. Here in Ohio, we're just coming out of the winter. Winter, not only do you have the seasonal affective issues, but there's huge issues with older people being isolated in their homes, whether that's due to mobility issues, snow issues, cold issues, whatever it is. People who are widowed, divorced, or separated. There was one fascinating study that looked at this and said, if people are single as a result of being lifelong single people, they actually do okay. But people who are single because they became single against their will are the people who are at most at risk. And we know that that also puts them at risk for earlier death. Lower socioeconomic status, that puts so many challenges on your day-to-day life. It makes you more socially isolated if you don't have car or transportation. More difficult if you're having trouble getting food. More difficult if you're having trouble getting the medications you need, getting the health care that you need. Comorbid general medical conditions. Again, people who are on multiple different medications, people who have conditions such as heart failure or other conditions that make it so that they're chronically feeling tired, chronically feeling short of breath, chronically feeling low energy. In addition to, as we saw on the last slide, things like Parkinson's, where there's huge issues with mobility, isolation, as well as comorbid potential for dementia. Uncontrolled pain is a huge issue, and people have, older people have a lot of pain. And it's very hard to try to figure out how to treat that pain in a safe way, in a way that doesn't give them complications from the use of narcotics. They also have complications from the use of other things. NSAIDs can cause high blood pressure, can cause ulcers, can cause all sorts of other illnesses. Tylenol, again, we have to be careful in dosing at lower doses in older individuals. And insomnia puts you at higher risk for depression. And many older people already are having some trouble with falling asleep. More importantly, they have trouble with staying asleep. So the average person falls asleep within 10 to 20 minutes. That's their sleep latency. And about every 2 hours, they get sort of a lighter sleep and then a deeper sleep, a lighter sleep, and then a deeper sleep. What happens when you get to be older is that every 2 hours, you actually cross what's called the sleep-wake threshold, and you're awake. And if you stay in bed and be quiet and don't, God forbid, turn on a phone, you will fall back asleep in 15 or 20 minutes. But it gives them disrupted sleep, which can be very difficult on your mental health. Recent onset of physical illnesses can be a huge factor, as we talked about with multiple, myocardial infarction, other chronic cardiac disease. Chronic obstructive pulmonary disease causes both depression and a huge amount of anxiety. Even simple things like chronic arthritis, causing mobility, causing pain, putting them at much greater risk for depression. The severity of physical illness is important. And it's important to realize that they will underestimate. If you say, how physically impaired are you? They're comparing it to how they were a month ago or a year ago. Because you may look at somebody, you'll think, boy, this person can do almost nothing. And they'll say, yeah, I'm okay. I'm fair. And it's sort of when we put our young eyes against looking at somebody who's 80 years old, we have to be a little careful. Functional disability is huge. People who have the inability to care for themselves. That causes huge issues of feeling like they're a burden to their family, feeling like they're a burden to society, feeling like they're non-productive members, and limits their mobility. Poorly treated pain and multiple illnesses, not only the result of the multiple illnesses, but the comorbid use of multiple medications. And we'll talk more about medications. So just one more quick poll here. Depression is normal aging, sign of a weak character, only affects the identified patient or a complex condition. And Darian didn't let me do the polls yesterday because I would have had to put April Fool's things into the polls.
A few more seconds.
So no, technically, it's really not a normal part of aging. Social isolation is a normal part of aging. A lack of potential activities is a normal part of aging. And to a younger person, that can look like depression. So I can see where you come up with that. A sign of weak character. I put that in specifically because oftentimes older individuals will not endorse depression because older individuals see it as a sign of weak character. They think that, oh, if I was just stronger, I wouldn't be depressed. And you oftentimes have to approach it with words like, well, do you feel sad? Do you feel blue? Do you feel low energy? If you use the actual word depression, you're going to get low yield on your ability to know who's got it. Only affects the identified patient. It obviously affects that person tremendously, but can have a huge impact on their family and the people around them. Obviously complex, you all did very well on that, thank you. So depression screening, there's a 2-question test, a geriatric depression scale, a 5-item. There's the PHQ-9, the PHQ-2, Cornell Depression Center for Epidemiologic Studies. All of these are useful tools. The PHQ-2 and PHQ-9 are probably the most common. They're used in the EPIC medical record, which is currently now about 67-68% of the American population is in the EPIC medical record for their medical records. What's important, though, is I want to talk about a thing called reflective empathy, because this is really where you as the community health worker are contributing more than potentially the provider who's seeing them in the office for somewhere between 6 and 11 minutes during an office visit. You've been interacting with that person potentially over time and potentially for a longer period of time during any intervention. And reflective empathy is basically when you're about to go into somebody's house or into somebody's room or talk to somebody on the phone, you start by asking yourself, how do I feel? And if you say to yourself, I feel okay, I feel fine, I'm having an average day, and you leave that interaction with that identified patient and you say, I now feel depressed, you have to ask yourself, Is the patient depressed? Did you reflect their mood and basically feel empathically the way they're feeling? Same thing works for anxiety. If you walk into a place feeling just fine and you walk out feeling anxious, there's a pretty good chance the person you were interacting with had an anxiety disorder. So even if it doesn't, you know, feel like they're scoring that way on a test, if your gut tells you this person felt depressed to me, trust that. Okay, because that's probably as reliable as any of these tests. The PHQ-9, little interest, again, not using the word depression, feeling down, depressed, or hopeless, trouble falling or staying asleep, or sleeping too much. We talked about the interruption in sleep, feeling tired or low energy, poor appetite, or overeat, feeling bad about yourself. This is one of the ones you got to be very careful with because you'll hear a lot of this sort of discussion in older individuals. Oh yeah, I'm not worth much anymore, quote unquote, feeling that they're a failure, feeling that they've let themselves down or their family down. Trouble with concentrating, not being able to focus, not being able to pay attention to what's going on in the news or watching television. And we talked about this when we did the dementia discussion. Depression can mimic dementia. It can make your cognition look impaired, moving or speaking so slowly that other people may have noticed, or being so fidgety and restless that you have to move around all the time and you can't sit still. Thoughts that you'd be better off dead or hurting yourself in some way. Score of greater than 10, and you can see the scoring there, is likely major depression. This is very useful because it's very quick. And obviously, if they answer the last question correct, you have to be able to get that person help immediately and make sure that that person's got a safe environment and a safe plan while that gets evaluated and figured out. What doesn't kill you makes you a bird. Every so often, Madeline gets carried away. So depression treatment should include which of the following?
Few more seconds if you would like to complete this poll question.
Everybody got that right. And it really is important because, unfortunately, too often in emergency rooms, urgent cares, or primary care offices, someone will get medication and not all the other things that are necessary in order to wrap it up. And it is true that there is, biochemical changes that are related to the, depression, its manifestations, its expression. And medications can change some of that biochemistry. But chances are that person's had that depression for a while. That's had an impact on their family. It's had an impact on their family support. They may have burned some bridges. They may have sort of lost some of their social network. If you think about it, people generally don't like to hang out with people who are depressed. So if somebody's been depressed for 6 months or a year, it's likely they're going to have a very, very small social network. And that may need to be rebuilt. Putting emotional support behind the medication support, helping them to rebuild their lives, helping them to rebuild their self-esteem. All that can be done in addition with counseling. It's oftentimes difficult to do it without some medication help, but not always. There are certain situational depressions, things that are around bereavement, things that are other issues that can actually be, you can counsel somebody through. The general rule of thumb is if somebody can't be sort of improved substantially in 6 counseling visits, they probably need some additional help from medication. And so you want to think about that in terms of making sure that they get all the support they need and not just some of the support. A little bit of talk about the drugs and the use of drugs. As we remember in pharmacology for older individuals, older people are taking a lot of drugs. About 50% of all the drugs utilized in the United States today is used by the population over the age of 65. And that population only represents about 12% of the population. 40% of elders are already consuming 5 or more medications. Over 10% are using 10 or more medications. About 12 to 30% of elderly admissions to a hospital are actually for a primary adverse drug reaction, not for a medical illness. And 25% of those drug reactions can be serious to life-threatening. Polypharmacy cascade, because I just told you, well, we want to give these people medications. You have to be careful because what happens is that you give somebody a medication, then they get a medication to treat a side effect of that medication, and then they get a medication to treat the side effect of that medication. And pretty soon they're on 5 or 6 different medications. Older people have issues with medications in terms of their administration, making sure they're administered correctly. Absorption. Now, you would think absorption would help because their absorption is not potentially up to snuff because their stomach lining is older. The problem is their passage is slower, so that medications have more time to absorb so they can still get high levels. The liver and the kidney, which are your two primary processing for medications, are both smaller, getting less blood flow per unit time. And so you're going to get higher blood concentration of medications in older individuals than in younger individuals. So they have more trouble clearing medications. Drug interactions increase dramatically with more than 6 meds and about 100% at 9 meds. And you have to come up with a deprescribing plan. So if you're putting somebody on medication for depression, you may have to take some other medications away in order to make room for it. And you probably want to have a plan that after a period of time, you're going to start to wean them off that medication and see if we can do that. In terms of which medications we're going to be using, the tricyclic antidepressants, which were your earlier antidepressants, were effective, but they had a lot of side effects. They had what's called anticholinergic side effects, which were the dry mouth, the other issues with low blood pressure, orthostatic low blood pressure, confusion. So we try to avoid those medications when we can. The MAO inhibitors were also again effective, but very much a challenge in utilizing those for older individuals because they had some very scary drug interactions, some of which were actually fatal. The SSRIs and the NSRIs, which are the serotonin reuptake inhibitors, your most common Zoloft, Prozac, that kind of thing, the newer Effexor and those drugs are very effective and actually quite safe. It's interesting that you usually start at a low dose. If I was depressed, I would be taking Zoloft. They might start me on 100 and I would quickly be on 150, maybe even 200 for a guy my size. When you're starting an older individual on Zoloft, you may start them at 25 milligrams. Or if it's somebody who's, 90 years old and weighs 85 pounds, maybe 12 and a half. You got to be very careful that you're sort of building up very slowly to get the effect. Problem with some of these medications is that they do take 3 to 4 weeks in order to get an effect. And so you have to have a good follow-up system in order to be able to assess. And again, a community health worker who can be in touch, be in tune, keeping track of that person is very helpful. There is that sort of scary reality that if you take somebody who is in what we think of as a psychomotor retarded depression, which is basically somebody who's so depressed that they're sort of very slow, that you give them some SSRI, the first thing they may get back is their energy, but they may be more depressed. They may still be very depressed. And there is reports where that growth of energy prior to the depression feeling better is a point in time where people have committed suicide. And we can't sort of get past this without talking about suicide, because suicide is the scariest result of depression. It's interesting to realize that despite the fact that older individuals do not attempt suicide as often as younger individuals, particularly older men are more likely to have a successful suicide. It's a weird way to phrase it, but it's a suicide that actually leads to their death. Partially, they tend to use more lethal means. Partially, they also tend to have less physiologic reserve to fight off the results of whatever their suicide attempt was. In terms of assessing for suicide, first and foremost, think about it, ask about it. Asking about suicide does not cause somebody to commit suicide. But there's also certain other questions that are very helpful. If you say to somebody, well, do you have any belief that you can feel better in the future? And they say no. That's something you should take very seriously. You know, if somebody's basically thinking they have no hope for the future, that's something you got to be very careful with. Also, people who are sort of feel like there's just, nothing to look forward to. They have what's called true anhedonia, which is the lack of pleasure in anything. Now, if you ask a depressed person, what do you enjoy doing? They'll all say nothing. But if you do a follow-up question, say, well, what do you do? Well, I watch football, or I watch basketball, or, I go to my church group, or whatever it is. And you say, well, do you enjoy that? They say, well, yeah. And, and if you say, do you have anything you're looking forward to? Usually they'll say no. But you say, well, what about, is anything happening at Memorial Day? Is anything, oh, my grandchildren come over for the parade. Oh, are you looking forward to that? Well, yeah. So you may have to do a couple of follow-up questions, but if somebody just persistently says, there's nothing in my life that's giving me joy right now, there's nothing that I'm looking forward to, those people are likely to require admission or at least being seen by a psychiatrist. I did mention electroconvulsive therapy, which I need to just sort of briefly discuss, just because it's got a sort of bad reputation in the world. It was used for way too many things, totally inappropriately, and actually is outlawed in certain places. I think it's still illegal in Puerto Rico. But it's got a role for what's called true psychotic depression. A psychotic depression is usually somebody who's so depressed that their thought processes are not logical. So the classic is they will have thought processes that are what's called mood congruent delusions. So there'll be delusions that have a very negative character. Oh, I'm dirty. I'm bad. I'm this. I'm that. Or a paranoid flavor. Oh, people are trying to hurt me. We've had patients who basically they won't eat because they're convinced that they're just such bad people and the world's trying to poison them. And that's, those people actually respond to electroconvulsive therapy. It's not something that can be done without all the other emotional, family, counseling supports and potentially follow-up medications. But it's something to remember as one of the choices in the armamentarium. Does anybody have any questions before we move on to the case presentation, or we can use that for our discussion? I don't know if there's anything in the chat, Darian. I've been sort of chit-chatting.
Yeah, we do have one prior question about family support. What if there was no family support for the individual?
If there is no family support, that's a huge issue. And it's really important to try to figure out what other supports exist. So, like here in Northeast Ohio, we've got the Benjamin Rose Institute, which does some community supportive counseling, and they do that telephonically, in addition to doing that in person. Similar resources exist in other places. Working with your mental health board to try to figure out what resources are there, whether it's resources through the church, resources through the mental health safety net. There's ways to try to find people support who don't have quote unquote family support. But that is a huge issue, and those people are very at risk. And finding ways to get them into some sort of group is very helpful, because if you can get them into some sort of group therapy or group environment, the PACE program, which exists, the program for all inclusive care, people meet as a group on a regular basis. Those kind of things can be very useful. Psychologists, social workers are very helpful in terms of being supportive environments. Any other questions in the chat?
Nope, that's all.
All right. Eleanor Roberts, 82 years old, major depression 6 months ago, hypertension and arthritis. Lives alone after the recent passing of her spouse. Former librarian, enjoyed reading and community gatherings, but has become increasingly isolated. During the home visit, expresses concerns about her declining mental health, feeling persistently sad, not sleeping well, lacking motivation, eating less, lost interest in her friends and hobbies. Tell me what your thoughts are about how to support and how to help Miss Roberts.
And if anyone has any comments, you can raise your hand. You don't have to come off video if you're not comfortable, but you can unmute or put your comments in the chat.
Well, I would definitely get her connected with like a social group, maybe like a book club, since she used to enjoy reading and things like that, and then that would get her out of the social isolation and back into doing something that she likes to do. If she's having trouble eating, then she may have some depression issues. So getting her connected with a behavioral health, or maybe depending on how severe it is, calling 988 and getting her with some immediate crisis care if that's necessary. And then they also do have home meal delivery programs. So if it's just a matter of her not really, having the motivation to do it, then that'll at least get her the access to the food again.
And it's interesting because some of that home meal delivery actually becomes a social contact as well. So yeah, those are all great suggestions. And as you said, going towards what she liked. So book club, maybe she could volunteer at a library, just to do a little helping out. Volunteering is a huge way to produce socialization as well as a sense of purpose. She's especially at risk because of the passing of her spouse, and there are bereavement groups that are very helpful, particularly if her husband was in hospice. They will follow her for at least a year with some support. There have been studies done that look at the immune effect and the T cell lymphocyte count, which is the cells that are affected in AIDS. An older individual in active bereavement has a T cell lymphocyte count lower than a patient with active AIDS. So they are very high risk for cancer and very high risk for other comorbid illnesses. What other ideas do people have for her? Sleep, eating, etc.?
I would want to know what her support system looks like already. If there's some support that's consistent there, and what she wants her support to look like from her perspective. Because sometimes we often know as professionals what we would want to be connected with, but what is her perspective? Let's ask. I would be inclined to ask her what's already happening, what's already in place.
That's a great idea because yeah, we don't want to start applying our ideas and not utilizing their ideas. I love the way you said that. So that's a great way to approach it. The other thing is to try to see if you can say, well, the next time I come out or the next time we meet up or whatever, who could you bring with you? Because, what you will hear is you will hear her say, oh, well, my daughter doesn't have any time for me. My daughter's just worn out. My daughter's this, that, or that. That may be true, but that may also be her depressive thinking to feel like she's a burden. And when you get the daughter in the room, the daughter's like, Mom, I want to do this, you know? And I mean, one of the phrases I used to use that I found quite helpful with some older individuals is, I would meet with the older individual and their child or children, and I would sort of ask the older person, what are you proud of? And universally, almost, they would say, well, I'm proud of raising my kids and taking care of my kids. And I'd say, so that helped you feel good about yourself to take care of them, right? And the older person would say, well, yeah. And then I would say, well, now it's their turn. And you don't have the right to deny them that good feeling about taking care of someone else. So you have to let them take care. It's sort of like just sort of flipping it a little bit to say, you don't have the right to refuse to let them help you. And that sort of changes their thinking a little bit sometimes. Other thoughts or ideas? These are great ideas.
We have some things in the chat. Ask if she would like to go to the library, adult day or senior center, grief counseling, physical exercise group in the community. Engage with her family and see if they can communicate with her and see her more often. Ask about her family support, community resources or social groups. Help her find a purpose or a new purpose.
You guys have hit all the major elements. I would just remember to throw church in there for a lot of older individuals. Church is a huge support system, and they may not be active, but they may have been active recently. And sort of their depression, they stopped going, whatever it is. What other education might we be able to provide for Ms. Roberts?
We actually have some grief workbooks that we use at the department. So getting her the workbooks and working through them with her so she can basically unpack what she's experienced with losing her husband, and then also uh, talking more with her about other resources that she can tap into as far as continuing coming out of that grief, and then the next steps to get back to a new normal for her. Because a lot of times they say when a person loses their spouse, they're usually not far behind, especially after it's been about 20 or 30 years of them together. The spouses rarely survive without each other when that grief is untreated.
That is absolutely true. Yeah, and some of these people have been together for 50 years. Yeah, you're absolutely right. You know, again, as we talked about, I think in one of the other group lectures, messages of hope are important. education says we can help you get better. We can help you feel better. This is not hopeless because whether it's depression, but also somewhat an age cohort effect, because 20, 30 years ago, when their parent might have been depressed, there wasn't such good treatment. And they may have said, yeah, mom had the nervous breakdown. She was never the same. You know, that's what the old terminology of nervous breakdown. And helping them know there's really good choices now, really good treatments now that are out there that are available. All right. I did hear someone mention physical activity, which is huge. That's a huge help in terms of getting somebody some help with their depression. And it's sort of that classic, you know, when you say I should go to the pool and you say, but I don't want to go to the pool. I don't want to find my suit. I don't want to. When you get to the pool, you feel better. Okay. In addition, many of these are then social. Okay. And now a lot of the Medicare products include free memberships to social silver sneakers, other groups, you know, Tai Chi groups are known to be impactful not only for socialization, but improve balance, you know, so those are very helpful. What else can we do to promote mental and physical wellness for her?
I would just think keeping a consistent conversation going about her not being a burden. You know, this is something that, you know, you want to help. It's not something that even if it seems like she's just re-emphasizing that she's not a burden.
That is critical. And I like the way you said that. It's sort of like you just you can always do an I statement safely, and you can say, I enjoy taking care of you. I don't feel burdened by taking care of you. I feel better at the end of my day knowing that I helped somebody. You know, it's sort of like again that flip to sort of say, you're helping me by letting me help you. You know, any other novel ideas about social isolation or support?
Groups that play board games or card games in the community.
Yeah, the senior center we met that someone mentioned the senior centers, a lot of which will actually provide transportation, which is critical, especially in the winter in the Midwest. Go ahead.
Department of Aging and at the City of Cleveland. Local community center, the church.
What about community health worker and your role in coordinating their care?
Were you able to hear me? Sometimes my mic doesn't work. I wasn't sure. Sorry. I know with some of my clients, I'm a community health worker. I try to connect with them out at like a very simple Tim Hortons coffee shop, something like that. Sometimes just getting outside of the house for something as very simple as a cup of coffee can go a long way in feeling a little bit more social and more connected.
Absolutely. We won't talk about the donuts. We'll just talk about the coffee. Yeah.
Donut talk is good.
Donut talk is good. Exactly. You know, don't forget the critical role that sort of helping them make sure because they may not be accessing their primary care, they may not be accessing their, nurse practitioner, they may not be accessing whatever they need to access to get a real evaluation for potentially medication, you know. So in addition to all the social community resources, you guys play a critical role in making sure that they, because they'll tend to just ignore they'll ignore themselves, they'll ignore their health needs, they'll ignore their, not only are they not getting their depression dealt with, but because of their depression, they may not be getting their diabetes dealt with, they may not be getting their hypertension dealt with, they may not be getting their glaucoma dealt with, all those incredibly common chronic illnesses, talking to them about, how are you doing with filling your medicines? Are you doing that on a regular basis? Are you getting, do you have your whatever it is? There's so many parts to, keeping track of all, if somebody's got 6 chronic illnesses and 7 chronic medications and 4 different providers and so on and so forth, that's huge. And if you're depressed, all of a sudden you're just not doing it, or you're not doing it well. And you guys have an amazing ability to get people bought in. And, it's overwhelming that people trust the advice from a community health worker more than anyone else, more than their doctor, more than their pharmacist, more than their nurse. You're somebody who has a real relationship with them, and you're somebody who they see as a peer, and somebody who's often sort of, a peer, a friend, somebody they really believe in. And you can make a huge impact on their health.
Also, just to make them, just to lighten the load, because sometimes you talk all the medications and the doctors and all the stuff, just get them to smile and laugh. When's the last time you laughed? When's the last time you smiled? What makes you laugh? What makes you smile? Just have that conversation, because sometimes this can get heavy, especially when you're working with an individual that has had so much going on. Get them to laugh, because laughter is so underappreciated. And getting somebody to smile is just that'll lighten anybody's day.
That's why we started with the cartoons. Yep. It's critical. It really is. You are so right. So we talked about identifying signs of depression when they're reluctant. Anybody want to add anything as we talked about just sort of paying attention to the way they feel? Community resources. We touched on a lot of community resources that are available. Engaging in activities. Again, helping them find transportation. Physical health, you guys all mentioned that playing a role. And the ability to provide collaboration and coordination with their healthcare providers and their family members to get a comprehensive approach to their depression management. I mean, I think you guys are doing all the right stuff. You brought up a lot of the right issues. Before we do the last poll, just want to see if there's anything else you want to bring up or anything else in the chat.
There's one comment in the chat. Since she was a librarian, see if there's a writing class and have her write a story about her and her spouse's love story to share with her family. We did this with my grandma and have a book about her and how we all came to be, a legacy that we might have lost.
And that life history review has been shown to be very effective in depression treatment. It's sort of, we talk about life history review, and it's talked about as this brand new thing and so on and so forth, and a wonderful idea. But we all watch It's a Wonderful Life around Christmas, which is nothing more than a life history review. And it's, that's a great idea. And there are actually books that have guided questions to ask older individuals to get that life history review in place.
One more comment. Coming out from this long-standing winter, I hear a lot of clients are just waiting to get back outside and feel some sun. They know being indoors has been depressing.
Absolutely. Even though it's raining today, but that's okay. It's not snowing. All right.